Welcome to Robert Wood Johnson University Hospital, Somerset's Health Talk. I'm Dr. Douglas Ashinsky of Robert Wood Johnson Physician Enterprises, Warren Internal Medicine. A recent poll by the Kaiser Family Foundation found that nearly half of the adults under the age of 30, as well as 28% between ages 30 and 49, and nearly 20% of people ages 50 to 64 do not have a primary care physician. On today's show, we will talk about the importance of having a primary care physician and how RWJBarnabas Health and Rutgers University are making it easier and more convenient for you to access a primary care physician. Our special guest is Dr. Andy Anderson, who is the Chief Executive Officer of the combined medical group of RWJBarnabas Health and Rutgers University. Welcome to the show. Thank you for being here. First, tell us a little bit about yourself and a little background on who you are and how we came to get you as part of RWJB.
Yeah, thank you. Well, I am a primary care physician, originally from North Carolina, and spent about 25 years in the Midwest before entering New Jersey about 10 months ago. And my background, as I mentioned, is in primary care and in leadership. I've been very interested in healthcare as a means of providing better service to patients since I started in medical school, and have thought, how can we do this better for patients and for communities? And so I have a passion for primary care. I think primary care is really a fundamental part of how we are going to better deliver care to patients and communities, by providing better access, by providing better services such as preventative care services, by really coordinating care for patients between different specialists if needed, and really just focusing on health and trying to help people be healthier, and we can talk more about that this morning.
And your philosophy of care?
I think the patient is the centerpiece of care. That's my philosophy, and every person as a patient is different. And I also would say that people don't want to be patients. They don't want to be sick. They want to be people, and so the philosophy is to treat people as people, to understand what their needs are, to understand what background they have that might influence their health, and to try to partner with a person for their health and for their health care. So when we're thinking about health, I think about diet, exercise, sleep, stress, those kinds of things, and trying to give good advice around those. And then when I think about health care, if someone has high blood pressure or diabetes or asthma or other medical conditions, trying to understand how best to work with that person to manage those diseases. So it's often a medication treatment, it may be seeing a specialist, it may be changing something in their lifestyle, for example, that could help with their asthma or could help with their blood pressure control. But really the philosophy is partnering with the patient to best understand how to work together on improving their health and their health care.
Our audience reads all about in the newspaper about all these combined groups, et cetera. Mm-hmm. And as you are the CEO of the combined RWJBH Rutgers Health Medical Group, what is that group? What is that group, and what is the philosophy of that group? Mm-hmm. And what is going to make it be the most important aspect of that person's life?
Yeah, so the group is a large group. There's over 1,800 physicians across our entire medical group, which spans a big portion of New Jersey. About 6 million people will be cared for through our medical group. I would say historically, each of the pieces of the group, meaning each of the doctors or each of the doctor practices, has had differences in how they've approached their organization of their practices and different ways that they've provided care. I'm trying to provide a bit more standardization to make it easier for people to get into the practices, to make it easier for people to be referred. When we have a need, if someone needs a kidney transplant, we have great kidney transplant surgeons. We want to make sure that we coordinate, that we navigate, that we make it easier for patients to be seen by those experts. We also want to coordinate just access, so calling or even eventually directly scheduling to be able to get in to see a doctor. That often is through primary care. So part of the organization of these 1,800 physicians will be the primary care physicians within that group, and we've got, about 300 or so primary care physicians within that group of 1,800. My goal is to have those primary care physicians really start to work together as a big team, and try to set expectations of each other about these are the ways that we'd like to provide better access. These are the ways that we would together better manage diabetes across our entire patient population. So I think there's a lot of power in having a big group of physicians and having those physicians work together and coordinate care and really set standards that are the very best possible standards for access, for management of chronic diseases in other areas as a large group.
So again, the base for a large group, the best thing is to have a terrific primary care base, because that really makes or breaks a group.
Absolutely.
Your primary care physician, there's been recent studies published by both Harvard and Stanford that show people who have primary care physicians have longer lifespans than if they only have specialists as their physicians. Mm-hmm. Primary care physicians are important for the access that they provide as well as the communication that they have. Mm-hmm. The fact that someone can actually call a doctor and be seen that day makes a big difference in the world to that.
It absolutely does. And part of the value is having that relationship, if you will, with your primary care doctor who really gets to know you. And when you are sick, they can more easily understand what's wrong because they know your background, they know you, and they can much more easily understand how to try to fix it. And like you said, primary care for me is the foundation of a health system. If you don't have a strong primary care base, you don't have an effective health system. So you really need that place, that primary care. Some people call it a medical home. Primary care, patient-centered medical home is often what we call these points of access where patients are coming in to see their doctor and they're having just coordination of care, navigation of the needs that the patient has, and really, again, establishing that relationship over time with that patient-centered medical home.
As a primary care physician myself who started out as a solo practitioner, basically by myself with no clinical coordinators, no other team approach to medicine, by being part first of Robert Wood Johnson Physician Enterprise and now part of RWJBH, Rutgers Health Medical Group, it allows me to coordinate the care. It allows me to access the care. I have certain guidelines that I have in my office, but by standardizing the care along all of the primary care physicians that go down to Ocean County, the ones who are in Somerset County, the ones who are in Middlesex County, Essex County, Hudson County, it allows a patient to have a standardized type of care that's best for them.
Absolutely. And I'm looking at physicians like you who are really experts as we build our primary care practices across the system to provide the service that your practice, for example, provides. And it is a team-based approach. A physician can't do all of this by themselves, nor should they. Having a medical assistant, having a nurse, having a navigator type function is critical to enable patients to provide the best possible care for themselves and partnering with the team, if you will, to work together. Part of this too, I think, is providing that sort of platform. Part of it is the electronic health record platform in the background. Part of it is having good sort of analytics, good computer software that can enable us to present data. If we're tracking blood pressure or we're tracking, glucose control for diabetes, have really good data in front of us as doctors. It's much easier for us to counsel patients and make better decisions so that we know which medications are working or not working. Ideally, we're going to get to a place, and we have in some cases already, where people from their home are going to be able to download their weight or their if they have asthma, how well they're able to breathe that day. If they have diabetes, what are their glucoses? If they have high blood pressure, checking their blood pressure at home and really just downloading that data and having the physician look at it with them. There's a lot of power to that to be able to better manage some of these conditions.
Which is, again, the reason why most of us need to be part of a larger group like RWJBarnabas Health Rutgers. It allows us the whole continuum of what we can do in the office. It allows us to use the clinical coordinators that Barnabas provides for us that allows us to actually do outreach to the community. It allows us to actually speak, talk to, engage patients in the community and improve their health and possibly even avoid them needing to go to an emergency room, needing to go to an urgent care center. And with a good primary care physician, we're hoping that they can actually go and talk to their primary care physician first before they make the next step to the specialist. At the same time, it allows us to have the whole gambit of specialists, which we didn't have prior to all of this. And it gives us the access, and once RWJBH group is on board and we're all part of the EPIC system, allows my data to be electronically transferred to someone down in New Brunswick, or unfortunately, if they have some type of abnormality, allows me to send them down to Rutgers for the Cancer Institute. It allows a continuum of data.
And you mentioned EPIC, and we've made the decision to go to EPIC as the single platform for the electronic health record across the entire system. It'll be a multi-year process to implement that across the entire system. But like you said, it will enable us to have one record no matter where a person or patient comes, whether it's the emergency room or the doctor's office or the hospital. It will be one record. So it'll be safer in terms of having one list of medications and one list of medical conditions. And like you said, we'll be able to communicate with each other so much easier, whether it's a primary care doctor communicating with a specialist, or whether it's just a matter of having medication lists being exactly the same no matter where the patient goes. It'll be just so much better. And part of it is, too, the patient will be able to access their own records from their home. They'll be able to see, this is my upcoming appointment, this is my medication list, these are the labs that I've gotten back based on the recent blood draw that I had. It'll be much better to engage patients in their own health and healthcare by having a portal, is what we call it, for patients to be able to access through EPIC. So I'm really excited about EPIC.
And I can tell you, even just from yesterday, a patient who came into my office that I was doing a pre-op clearance on, who we actually had to contact the specialist to have them fax over blood work, and found out some abnormalities, which if it was all electronic, I could have done that all either at home or prior to the person coming in, which we could have gotten things done quicker.
Right. I think the fax machine will be obsolete, hopefully, soon, and everything will be electronic so that we don't have that sort of burden and that extra paperwork that's not really necessary. It doesn't help. It creates inefficiencies, and part of this is just being more efficient, more cost-effective, so that people have healthcare that's more affordable and easier to get to.
And more important is that it allows us to do what's called population health. Population health, meaning that we can actually improve the health of the people based on what type of conditions they have, and be able to do it both as an outpatient, inpatient, through the electronic portal, and then be able to take all that data and be able to say, you know what, your hemoglobin A1C is such and such. If we can do the following with it, we can reduce the complications of diabetes.
Right.
Your blood pressure is such and such. If we can reduce your blood pressure, we can reduce your risk of having a heart attack, reduce your risk of having a stroke. And by having that data in front of us, it'll tell the physician, if something's happening, this is what should be done. We can do proactive rather than retrospective or at that time.
Yeah, I think population health is powerful. I think when you think of a community like Somerset, for example, if we know in that community more clearly that there's a lot of diabetes, for example, then you're much more likely to be able to navigate services and make sure that there are enough dietitians, for example, in the community to be able to counsel patients about what they're eating, make sure there's enough primary care doctors with expertise and endocrinologists who are specialists in diabetes in that community to make sure that you're better able to care for patients. So, part of population health is understanding, what is the condition or conditions in that community that are having impact, and how can we go after it. Part of it, too, is connecting with community resources, so understanding where's the local gym, where can a patient go for counseling if they're stressed? Where can a patient go to get advice on their food, and where are healthy foods? Where does the grocery store have enough fresh fruit and vegetables? Those kinds of things. You really can better understand the needs of the community and try to connect patients with those community resources better. And again, primary care is the navigators, the quarterback is the centerpiece of all of that. The primary care office really is going to inform patients about where those resources are and be the coordinator of all of it.
Which again, being part of RWJBarnabas Health, it allows me to use the resources of the whole institution throughout New Jersey to obtain all of that information and to be able to get that information out there to the patients so that they can use it and improve their health as quickly and as most efficiently as possible.
Absolutely, and the whole continuum too that we've sort of been talking about is you've got people who are pretty healthy. We still want to take care of those people. And we've got people that are really sick, and we absolutely want to take care of those people too. And I believe we have the very best specialists, in New Jersey, if not the whole Northeast. And connecting our primary care docs with those specialists when needed is absolutely part of this. On the other side, again, people that are healthy, we want to keep them healthy. We want to have them be seen in primary care settings so that we can focus on wellness and make sure they don't get sick. If they have a family history of diabetes, we want to catch that early. We want to modify as best we can the risks for that and prevent them from getting to the place where they have diabetes.
And what you'll notice when you get into your primary care doctor's office is it's no longer really a physical that you're coming in for. It's not the annual physical. It's an annual wellness exam where you're not looking for illness. You're looking for what can you provide for that person to reduce their risks of turning into some type of a condition. So you're going to check on whether they've received their flu shot. You're going to check if they're above the age of 50, whether they've had their shingles vaccine or not. You're going to check whether they're above the age of 65, if they've had a Pneumovax 23 or Prevnar 13 vaccine. You're going to check on their height and their weight and make sure that their BMIs are within the standard limits. And if they are above it, you're going to give them some type of education as well as some type of clinical resources, which will allow them to hopefully bring that BMI under control and thus reduce their risk of turning either into a hypertensive patient or a diabetic patient.
Exactly, and cancer screening is important as well. The other area that I think is fascinating is trying to understand the home setting itself, and are there stressors in the home? Are there risk in the home if someone is older and they're getting a bit more frail? Is there a railing, for example, out their front steps? Are there loose carpets in the home that they could trip over? Really having a conversation about that can be very impactful and prevent someone from falling and breaking a hip, for example.
Which, again, CMS had started to institute when they instituted the Medicare annual wellness exam, where we specifically do ask, is there any, in the bedroom, making sure that there's no newspapers on the floor before the person goes to sleep so that they don't fall and trip. If there's any carpets on the floor that are loose. If the person is wobbly, do they have handrails in? Do they have handrails in on their bathroom so that in case they're on the bathroom, they need to get up and they feel that they're lightheaded, that they can hold on and reduce their risk of falling. At the same time, we're also checking on things such as depression, alcohol screening. We're checking on that. We're checking on the cancer screening, men for checking on their whether or not they want to be screened for prostate cancer. We're checking on colon cancer, making sure that people are doing stool tests as well as colonoscopies, and hopefully, again, sending them to the RWJB health system so that those things can be followed longitudinally. This is not something that we just do one time. It's something we're going to be following 30, 40 years down the road, and we want to make sure if I've had a colonoscopy in 2001 that we're going to do another one in 2011 and not say, oh, it was done 10 years ago approximately and miss things.
Absolutely.
Now, the other thing you also sometimes talk about is the cultural competence and compassionate care. You want to discuss a little bit about that and outcomes?
Yeah, so we talked about population health, but within a population, each person is different. So as a physician, the person in front of me is going to be unique and different than the next person. So, some of that is genetic, some of that is environmental, some of that is related to the culture that they have grown up in or the way they believe or practice things in their life. So I think it's critical for a primary care physician and for a health system for that matter to be sensitive, to be understanding, to be a good listener, to understand what the beliefs are, what the habits are, and to try to partner with a patient on how to improve their health and their health care by understanding who they are and what they believe and the types of things that they do or don't do. So again, everybody's unique. Part of that is related to decisions on how we treat people too. So I think we'll get better and better at this over time, but certain genetic profiles for hypertension are going to respond better to certain medications. Certain genetic profiles for diabetes are going to respond to certain medications. We're still learning about that. That's one of the values of being partnered with Rutgers and the academics and the research and understanding what is going to work. What is the best medicine to treat someone who has high blood pressure? If they're African American, if they're Asian, if they're Caucasian, probably it's going to be a different answer. We just don't know yet. We're learning. There's a lot of research going on to understand which medications work better in which populations, and some of that is just the genetics that you're born with. So I think that's really important.
Which again explains how important it is to be teamed up with the Rutgers and the Rutgers Medical School. Right. That we have these excellent physicians as well as these researchers, Nobel Prize winners, et cetera, that are doing research on what the next step is.
Right.
We know that with cancer, chemotherapy, radiation was what we had been doing, and now they're doing lots with immunotherapy, which can be all that be accessed down at Rutgers Medical School. And again, we do have now partnerships with them, which allow us to take people from Essex County, bring them down there, and be able to give them state-of-the-art treatment.
Mm-hmm. So yeah, the latest, the greatest, the best evidence, if you will, for what works and what doesn't work. Certainly cancer, there's so much opportunity there, but a lot of the other fields too, such as neurosurgery and cardiovascular surgery, the TAVR procedure, for example. There's other just sort of late-breaking new technologies, robotic-assisted procedures that are better for patients because they're less invasive, there's less side effects, it's an easier transition from the surgery to going home. So there's a lot of work being done on that to understand, what is the best treatment from a patient-centered standpoint. So I'm excited about that.
And even better is the fact that we do not have to send people to New York City for that.
Correct.
The people can do it at their local hospital, which allows them to be discharged sooner, allows their family to be with them both in the hospital and post-hospitalization, allows community resources in the area to be used much more efficiently, and thus the patient gets through the procedure or gets through whatever's necessary quicker, easier, more comfortable, and closer to home.
Absolutely. We've got everything we possibly need in New Jersey itself, so no need for New York or Philadelphia for that matter. And wherever possible, patients do better when they're in their own community. So I'd say 90–95% of what someone needs when they're sick is likely to be in their own community. There's still going to be those instances of people needing to go to sort of a flagship for their kidney transplant or their liver transplant or certain cancer treatments, and we have those too. So we have hospitals that are focused on those within our system, and so 5% or so of the time, easy to navigate, from a patient standpoint, to go from their community to one of these flagship sort of, we call them quaternary centers that offer these very advanced, unique opportunities to treat those who are very sick. But again, most people can get their care in their own community. And again, it starts in primary care. It spans out to specialist care. And then when someone gets to the point where they need to be in the hospital, then they will be well taken care of in the hospital as well. And we're trying to focus on keeping people, out of the hospital as much as possible. It's appropriate. If someone needs to be there, they need to be there. But if not, it's safer in your own home. And we're trying to help people stay in their own home as much as we can. And
since we're all part of RWJBH Rutgers Health, we really want everyone to have a primary care physician who's part of that organization.
Absolutely.
By being a patient who is part of that organization, it allows you to access the primary care in the primary care office or down the road, probably through telemedicine, et cetera. It'll be able to be accessed either on your iPhone or at home, so that you may not have to go into the physician's office to be seen, heard, or be taken care of.
Yep.
Your data will be able to be easily picked up at home, and you can discuss that with the physician either during an office visit, prior to an office visit, after an office visit. If you do need further care, we have the clinical coordinators that allow the clinical care. We have all this, and then the important thing is the specialists. We have the board-certified fellows in multiple specialties who are basically the top of their specialists, and we can do that in the community.
Yeah, just as I said earlier, the primary care home really is your quarterback, your navigator, your coordinator for everything, from wellness to sickness. And our goal is to provide easy, timely access for patients to be able to get in. And like you mentioned before, I think we're going to get better and better about telephonic conversations. Video visits are on the horizon to enable patients to see either someone in that particular office or someone who's closely affiliated to be able to care for them in a timely manner. But easy access is my goal.
So the big thing is for the patients out there and for the audience out there, think of getting yourself a primary care physician who's part of RWJBH Rutgers Healthcare. Those physicians and they first have to meet New Jersey guidelines, they have to meet Rutgers guidelines, they have to meet Robert Wood Johnson guidelines, Barnabas guidelines. These are your top primary care physicians in the field.
Absolutely.
They're going to be able to access the care, they're going to be able to give you the communication that's necessary, and if necessary, coordinate your care through the whole spectrum of the healthcare system. They'll get you before, they'll be able to coordinate your care prior to coming into their office, during the office visit, after the office visit. If they need to send you to a specialist, they'll be able to help guide you through that also. It's almost as if you're being treated like a concierge patient and not having to spend the money on a concierge physician.
That's the goal. That's how we want our patients to feel. We want our communities to feel they have easy access. And it's really an exciting time in healthcare. I think historically primary care perhaps hasn't been recognized as fully as it should have been, and now it is. Now everyone understands how important this is, how vital this is to keep our communities healthy, to provide great access for patients to primary care. And every patient really should, every person really should have a primary care physician as their coordinator, their navigator, their quarterback for their health and their health care.
Thank you very much for being here.
Thank you.
This concludes today's episode of Robert Wood Johnson University Hospital's Health Talk. Please remember the opinions expressed here by a medical expert are not a substitute for medical advice from your own physician. If you need a physician, please call our physician referral line at 1-888-724-7123. For more information about Robert Wood Johnson Hospital Somerset, please visit our website at www.rwjbh.org/Somerset. Thank you very much for being here, and thank you for helping to coordinate primary care in the RWJBH Rutgers health system.
Thank you.